Next up, we have our first panel discussion on emerging from the impact of COVID-19, a public health perspective. It is indeed an honor for me to introduce our renowned contributors. Let's start with our eminent moderator, Ms. Safaa Almajthoub, Director of Strategy and Governance, Digital Health Center of Excellence, Ministry of Health, Kingdom of Saudi Arabia. Dr. Ahmed, Safwat, Board Member, Egyptian General Authority of Healthcare, Accreditation and Regulation. Professor Michael Miller, Digital Health Technical Advisory Group, Roster of Experts, World Health Organization. And we have with us Professor Rowaida Mahmoud Al-Maaitah, Advisor to Her Royal Highness Princess Muna Al Hussein, Health and Social Development. Over to you, Ms. Safaa, to moderate the session, and the stage is all yours.
Yes, thank you very much. So I'm going to start this panel by stating some facts based on McKinsey report I went through recently. So this report basically indicated that approximately 250 billion of spending on traditional healthcare will be diverted to telemedicine services. And the report also indicated that the demand for telemedicine has increased by 17% since April 2020, and that telemedicine services have multiplied by 38 times compared to the base point before the corona pandemic. So the investment rate in providing telemedicine services in the first half of 2021 reached levels of approximately 15 billion, which is double the investment in telemedicine during 2019, which was 7.7 billion. It's likely to reach levels of 25 to 30 billion dollars. So as a local indication as well of telemedicine adoption, I can say that the number of beneficiaries of telemedicine platform recently, the Ministry of Health platform recently have reached nearly 1.5 million beneficiaries. And further, telemedicine is no longer a luxury, but it's a reality of healthcare delivery. The Ministry of Health 937, for instance, call center and Safaa virtual hospital are great local models in this field, where virtual hospital provided its services to nearly 33 hospitals across the kingdom, providing nearly 33 specialties and subspecialties. And this is going to be just the base, and more services in this provision will be even expanded further. However, the adoption of digital health is still facing challenges, especially when it comes to bring together and align interests of major stakeholders, such as investors, entrepreneurs, patrons, regulators, to basically meet the population health needs. So, according to the research conducted recently and by comparing global experiences, some health systems globally actually have adopted a concept that is called regulatory sandbox, or digital health regulatory sandbox. And this is what's been activated recently in the Ministry of Health. So what we're doing in this model, we basically provide a safe environment for entrepreneurs, investors, to test the new technologies within 4 to 6 months, as what we call a proof of concept. During this experiment, we basically test the solutions from different perspectives: the clinical aspects, the social aspects, regulations aspects, and so on, and even the economic impact, and so on and so forth. And we divided it through different waves. We made the first wave to meet certain population needs, for example, diabetes, some nephro diseases, and so on and so forth. And we filterize those solutions based on those needs. We test it out. We make sure that the solutions is proved to be impactful. Then we start taking it through a different pathway where we can actually accelerate the model at national level and scale it up, either under the umbrella of Ministry of Health or with collaboration with private sector, and so on and so forth. So I think based on these challenges, for example, recently when we hear from stakeholders like investors, they lost guidance on where to invest in digital, in healthcare in general. Also, when you ask the entrepreneurs, they're lost in the system because they don't know how to actually scale up their solutions. They don't have access to data where they can access and basically prove the concept of the solutions they came up with. When you look at patterns, just like us as Ministry of Health, you lost opportunities as well because of lack of having such a systematic approach. So bringing together all interests, that will be very much helpful to navigate and also to test out those solutions and prove its concepts and then scale it up. Speaking of business models and scaling up the solutions, I think it's going to be a good introduction to our panelist here, Dr. Ahmed Safwat. We would like basically to hear and from you, so you can share with us more insights probably regarding how to develop national business models of telehealth. I mentioned earlier that sometimes we reach to the point where the technology is good and we're really ready to scale it up. It's really impactful. We really want to use it, but sometimes we're stuck with which business model to go with. How can you benefit from the solution the most? So please highlight more on this area. That'll be much appreciated. Please go ahead, Dr. Ahmed.
Thank you so much, Safaa. Really, I'm not able to express how pleased and honored I am to be here with you discussing such an important topic. Ramadan Kareem, كل عام وانتم بخير. Actually, for any country to be able to practice and implement telemedicine in an efficient, effective, safe, and patient-centered way, you need to develop your own national business model to do it. Otherwise, you will not be able to do it that way. And to be able to develop such type of business model, you need first to prepare your context of your business model, the background of the business model. And here, when I'm talking about the background, I mean the needs, the purpose, why you need to have this telemedicine implemented in your country. Are we talking about deficiency of or shortage of facilities or professionals? Are we talking about timely coverage? Are we talking about avoiding infections or crowdness? What is the purpose? And here come the needs. Then from the needs, we'll go to the targets. And the targets are related to the phases. What we need to be done in phase 1, phase 2, phase 3. So what are our goals of the model? Then the third part of the background of the model is the risks we need to avoid if we are going to implement or practice our telemedicine model. For example, we'll find some security risks, some safety risks, some legal risks, some technical risks. So we need to have a very comprehensive risk registry to decide which risks we are gonna accept, which risks we are gonna mitigate, which risks we are gonna avoid, and which risks we should eliminate. After we finish from doing this model background, here we can start doing our real model. And doing the model, to do the model effectively, we need to answer some questions, starting from defining our telemedicine use case. Here we need to define it according to the individual involved. Is it going to be physician to physician, patient to physician, patient assistant to physician, according to the purpose of consultation? Are we going to doing it during a non-emergency situation or in emergency situation? If in emergency situation, are we talking about first visit or from the follow-up visit? According to the scope, which services to be included in which phases? Because we talked before about targets according to phases. So are we going to include teleconsultation only, or we'll have teleprescriptions? What about telediagnostics? What about procedures? And what about telemonitoring? And telemonitoring, is it going to be done just with facilities like tele-ICU, for example, or we can have telemonitoring at homes using the telehealth toolkits? Then we need to define the relation with and components of medical records. Are we talking about interface integration or manual referring between the facilities? And still while we are creating the business case or the use case, we are talking about the mode of payment. Are we talking about out-of-pocket or insurance? And if we're talking about insurance, are we talking about general insurance or governmental insurance only, or the private insurance can be there? Then according to the mode of communication, are we talking about video or audio or data flow interface or text-based? Till we'll go to which type of the timing of data transfer. Are we talking about real-time data transfer or asynchronous or canned data? This is the first part of the model. It's called creating the use case. Then we'll go to the second part with creating the case flow or the workflow. What's supposed to be the starting point? Are we going to start from the on-site, then to go virtual, or we can start from virtual and continue virtual? Then what about the second opinion, the referral, the consultation? What about and referral at the same level or at between different levels? Then how to proceed through the investigation, then the e-prescribe, then the built-in billing system. What about the complaints and response to deviations? Then the third part of this model should be related to the technical specs. This should be related to the data volume, flow, management, and governance. And while we're talking about the technical specs, we should be very aware how to deal with the patient with special needs, how to deal with the psychiatric patients, for example. Putting into consideration the current structure and infrastructure we have in our country and what we need to have to settle a well-developed business model. Then we come to the legal part, the legal aspect. It's very important. What about the licensure? Are we going to do licensing to the professional only, or to the provider only, or to the application only, or all of the above? Then what about the professional authentication, patient identification, privacy, security, confidentiality, sharing information and data governance, different levels of liabilities, what to do in case of discontinuity and artifacts drawbacks. Then the last but not the least important part of the model is related to the continuous monitoring and evaluation to have continuous improvements. Actually, these are the main pillars of the business, of the detailed comprehensive national business model to implement telemedicine in any country.
Thank you very much, Dr. Ahmed. That was very insightful. And I'm glad actually you've highlighted you highlighted on the areas that where we really need to understand the use cases, and we really need to do our baseline assessment carefully before we actually choose and select which business model is going to be the most suitable. Thank you very much again. Really appreciate your inputs. Would you like to share probably some points with regard to the barriers to implement the model, or any type of model, like some barriers and challenges that might hinder the implementation? Yeah. Actually, the main barriers from my experience working in this field since long time, I guess. First, we can start from the top leadership. We have two main barriers. The first one is the false perception of the lack of demand. They may think that no need for that. People are not gonna work with that. People will not here. They are not talking. They are talking about the patients. Patients, no, they do not need this one. So the false perception of lack of demand. This is the first barrier. The second one is related to, again, the false perception of high cost of the telemedicine. And actually, the fact is that absolutely the reverse of this information, that it's much cheaper and much efficient than the traditional or the traditional way of treatment. Then the other two barriers are related to the legal barriers.
And actually, most of the countries I've met, and I've had some project where they do not have a well-established legal framework for telemedicine there. Most of countries, or many countries started 1 or 2 years back, but still even the legal framework needs to be a little bit customized and adjusted according to the local context there in these countries. And the last, and also but not the least one is the clinician resistance. And actually I'm facing this resistance from the clinicians because most of the old school clinicians, they are not very convinced of using telemedicine unless just for some video consultation, and they think this only the way to have this telemedicine, disregarding the barriers. But actually from the lesson learned also from the successful countries to bypass these barriers, I would recommend 5 main steps. The first one, to get everyone on board while you are developing your business model. You need to have the clinicians, you need to have the telecommunicators, you need to have the financial department, you need to have everyone. Every related stakeholder should be on board. The second recommendation is to go with your local context. Don't copy and paste. Whatever, however successful is the model in the other country, this doesn't mean that that it's gonna work in your country. So you need to go with your local context. The third one, start simple as you can, then go complicated. The fourth one is really proper phasing is the key of success here. Start with phase 1 with your targets clear and obvious for everyone, then go to phase 2, then go to phase 3. Don't start mature while still you are not immature, you are not mature enough. And the fifth recommendation, again, keep your eye in your system. Continuous evaluation is the real key for continuous improvement. Actually, this is the way how to overcome the resistance and how to get your business model implemented as easier as possible.
Thank you very much, Dr. Ahmed. That was very insightful. Now I'll move to Prof. Rowaida. Prof. Rowaida, can you please share with us from your experience, some points with regard to post-COVID-19, like what is the main predicted healthcare shifts probably in 2021 and beyond?
Thank you so much. And I'm so happy to be part of this panel. I just want to take from Dr. Ahmed, saying that, when we invest in technology, this is not, actually a cost, it's really investment. So this is not a cost. So I'm so happy, of what you just said, but just to remind everybody, this is an investment and not cost. And Safaa, I'm gonna skip the vacancy because you already talked about the vacancy report. We are in the same page, I think. But I'm gonna go to the World Economic Forum 2022. The World Economic Forum, they said that the innovation industry has been a massive wave of investment. Innovation and new entrants from the technology, telecom, and consumer countries in industries. For example, in 2021 alone, 44 billion was raised globally, and health innovation twice as much as 2020. And the acquisition of health and health tech companies rose up to 50%. So today, I would like to reflect on the World Economic Forum annual virtual meeting in January 2022, where the agenda of the meeting covered both, the vaccine equity as well as innovation, in addition to technological cooperation. But ahead of the virtual meeting, industry leaders were asked to reflect and predict the biggest shifts we can expect to see in healthcare in 2020 and their outlook for the future. So here are some selected actual trends or shifts. I really want to share this with everybody because I think it's really very important, and it is the talk of the day, like they said. So the first selected biggest shift we can expect to see in healthcare in 2020 and beyond is the need for thinking and acting as a global society. Considering the pandemic's magnitude, it is more important than ever the public and private stakeholders work together. Investment in health technology is expected to continue to be strong in 2022, and collaboration between industry partners, like you said, Safaa, with interdisciplinary skills will become the new normal. So we move to the new normal. And we know, like McKinsey said, we were like normal, moving to new normal, and then we will move to the next normal, actually, into beyond the 2022. So, and in order to succeed, what we need to do, we must think and act as one global society. So many digital health trends will accelerate to make patient care more precise, personalized, and connected. Different innovations will improve the health of people this year and beyond, such as Internet of Things and artificial intelligence, machine-to-machine communication, and other technologies will continue to improve the productivity of patient diagnosis and treatment, as well as research and development. In addition, the world will witness more incremental advances across connected drug delivery. Wearable devices and apps will also improve levels of patient engagement and adherence. The second shift is about digitally enabled care is at the heart of healthcare transformation. Digitally enabled care will be at the heart of healthcare transformation. So digitally enabled care will underpin a future healthcare model that is more accessible, effective, sustainable, and resilient. For example, artificial intelligence supports clinical decision-making, improves the care planning and efficiency, and powers workflow automation. Such digital healthcare transformation presents opportunities for a greater shift to remote patient care through telehealth. Also, like Dr. Ahmed also said, also behavioral, including mental well-being, health improvements in population can be handled by coaching and gamification. So the digitally enabled care transformation will be achieved through deep partnership with aligned objectives between governments, providers, payers, and technology companies to make change happen in a sustainable way and improve the lives of billions of people. The third shift is a shift toward new models of care. The pandemic also exposed long-standing weaknesses that we already know about all over the world in our healthcare system, including the Eastern Mediterranean region, our region, as they bulk under the strain of health crisis, which means a shift toward the new model of care is highly needed, with an emphasis on preventing, diagnosing, and treating disease early, and powering transformative innovation to improve patients' outcomes, which in turn will help in addressing the long-standing burden of disease, such as chronic illnesses, diabetes, heart problems, and others, and ensure the resilience of our health system against future shocks. So we learned a lot from the COVID-19. The pandemic has also created new opportunities. The adoption of digital health solutions took a quantum leap. For example, patients and health professionals are experiencing now remote care, experiencing how remote care can be more timely for patients, reduce hospitalization, and increase health workforce effectiveness. The fourth shift is technology is the great equalizer, and I really like this because health inequity is another global crisis magnified by the pandemic. And we witnessed that in the disruption of services, in the vaccines, some countries, they easily get the vaccines, others, they don't. So while the pandemic intensified disparities, it is also catalyzed a surge in digital transformation. Therefore, we must make technology work harder to begin balancing the health equity scales. For example, The rise of chronic diseases poses a significant threat to public health. If we are to close the gap, we must act quickly, and barriers to education, diagnosis, and treatment must be urgently addressed. So it's vital to look at the full spectrum, from developing technologies to reach more patients in new ways, such as at-home exams and remote screening, to enabling community healthcare workers to do more, such as expanding access to expertise via virtual training. Therefore, it's imperative to develop equity-informed technology in order to create lasting solutions. The fifth shift is entitled like this: it is not enough for artificial intelligence to be smart, it also needs to be wise. And yeah, I also like this one, because artificial intelligence is beginning to transform healthcare, of course, and we all know artificial intelligence can diagnose some medical conditions more accurately than a human. However, it is not enough for artificial intelligence to be smart. Like I said before, it also needs to be wise. Smart, that is precise and reliable, and wise, that is well governed and applied in optimal value-creating ways. For example, artificial intelligence might be able to identify cancerous tumors, but it is humans who need to decide which kind of cancer should be targeted and at what stage. Therefore, wise use of artificial intelligence creates both new responsibilities and new opportunities for doctor, policymakers, and health companies. The last selected shift is championing digitalization in trials. It's interesting that many trials now use at-home patient assessment, but digitalization of trials will see further innovation in 2022 and beyond. For example, one of companies had made further efforts to modernize clinical trials by incorporating technology that allowed it to conduct and remotely monitor more patient-centric clinical trials in cooperation with regulators. By the end of 2020, 76% of the clinical trials conducted most of or all site visit monitoring remotely, compared to 18% only in 2019. Access to clinical trials can be, of course, excellent and can be expanded to more patients. It covers more patients. Then human diversity also will be better captured in research, and possibly new breakthrough therapeutic solutions developed faster. In summary, and I want also to add to Ahmed, because I really like what he talked about the priorities actually to solve the problems. Of course, political will is also very important in addition to leadership. Also, we need to invest more in people and in youth. Also, we need to transform the education system at the universities. Also, the environment should be also much better. It needs to be a decent environment for the workers. And again, it is an investment and not cost. My summary is that advancement in data, artificial intelligence, and other technologies is increasing the high potential for custom-made healthcare to keep expanding while bringing down the cost of healthcare. It is also increasing and maximizing the possibilities from the ability to design the most effective prevention and treatment plans for such individuals, to better accommodation of personal preferences with regard to risk or medical interventions. With a fundamental shift in thinking that had been beginning to make the most of the digital revolution, it is now possible to deliver healthcare that is highly individualized, opening up a brand new era, which is now called the greatest happiness of the greatest diversity. Greatest happiness for the greatest diversity, rather than what is called the greatest happiness of the numbers. First, we were talking about numbers, but now we're hitting, with the technology, we will hit that diversity. So definitely a more sustainable future for health relies on new model of public-private partnership. It requires all stakeholders to think differently, and this is important, to think differently about health investment, moving away from a short-term saving mindset to ensuring long-term benefits to healthcare system and economies. Finally, I think you might, I'm sure that you will discuss this in some other sessions, but also I would like to mention that cybersecurity remains as important concern for the health sector, which lags, we all know it lags, that sector lags behind other critical infrastructure in cybersecurity. A high level of cyber risk has emerged during the COVID-19 pandemic, which poses a threat to all health processes and professionals. WHO actually reported five-fold increase in cyber attacks during the pandemic in 2020. So this is an important area that we need to tackle better, to manage it, to work for it in public health and health technology. Thank you so much.
Thank you very much, Prof. Rowaida. That was amazing. I learned personally a lot from your speech. Thank you very much. And I like the statement that we don't have to have it smart but wise. And you need to really use technologies wisely and apply it to the system wisely, considering different aspects. That was very insightful. Thank you. And I'm sure that the audience today was watching us are benefiting from all the panelists actually in this session. Thank you so much. Now I'm moving to Prof. Michael. Hello, Prof. Michael. I have my first question ready for you. So what do you see as the what do you see as the effect of the pandemic on telehealth, and what opportunities does this offer for telemedicine in delivering healthcare? If you can elaborate more in this area, it would be much appreciated.
Yeah, I think overall the effect of the pandemic has been to move us more quickly towards the acceptance of telemedicine as a mechanism for delivering healthcare. That said, I'm not sure if it's a transitory effect or it will continue. My hope is that it will continue because I think it's necessary for a number of reasons. Not least of all, the lack of availability of clinical staff, clinicians and support staff, the increasing costs and burdens on healthcare, that in many countries around the world it's becoming fiscally unsustainable. So if we look at the United States, for example, we're approaching 20% of GDP for the cost of healthcare. Similar problems, although not quite as large, in Australia, right across Europe and many other countries around the world. So we need to find a way of delivering more affordable healthcare to an increasing size of population, also a population suffering with the issues of demographic change, of aging, as well as, of course, the problems of chronic disease and the growth in chronic disease. More people will now die from preventable diseases than contagious diseases, excepting for the transitory effect of the pandemic. So we have to look at the whole way that we deliver healthcare. We can reduce costs, we can improve outcomes, and we can improve access. That's what I think the possibilities are for delivering healthcare. However, there are a few issues around that. One of the encounters, or the acronym used to define the encounter between a patient and a clinician, is SOAP, Subjective, Objective, Analysis and Plan. The problem is with many current telemedicine systems is that the objective element is missing. So yes, I can see a clinician. Yes, I can describe the subjective element of it. But the objective element, if the clinician wants to take some vital signs measurement is often missing. So telemedicine is largely a political solution. I've seen a clinician, but I'm not sure as yet it is a technical or clinical solution, because we need to be able to introduce the objective element, the measurement of vital signs, into the whole process. And then I think telemedicine has more significant value. It offers the opportunity for delivering integrated care. It offers the opportunity of preventative healthcare, moving away from a treatment-based healthcare system to a more preventative healthcare system if we can monitor patients continually. And it would facilitate the segmentation of patients on the basis of risk. So, for example, as we see in the Middle East, the IDF, the International Diabetes Federation, predicts that the number of diabetics, largely type 2, will increase by 96% by 2045. How do we check on those that are most at risk, most likely to develop some acute complications, be that stroke, cardiovascular disease, or the requirement for an amputation, as an example? If we ask most clinicians in their practice how many of their diabetic patients are most at risk from an acute complication, they're unlikely to be able to tell you because they don't have the data in front of them. If we could stream the data continually, and I'll go into more detail of that on the second question, then I think we have the ability to identify those patients and use our resources most effectively to actually get to those patients that are most at risk. And why do we want to do that? Two reasons, I think. The first is the cost of dealing with acute complications is extremely high, although I'm less bothered by that. But the second option is they're life-changing for the patient, to lose a limb, to have a stroke, to have a heart condition. So we need to be able to develop a method of delivering healthcare that continually monitors patients, and that we're able, therefore, to deliver a much more effective healthcare system. But that's my opening gambit. Next question.
Thank you very much, Prof. Michael. Actually, my second questions will be a follow-up questions, like what steps need to be taken to ensure the benefits of telemedicine, telehealth can be harvested for both patients and healthcare providers?
Okay, I think the first thing is the question of access to data. Many countries have invested in electronic health records. And it's 50 years since Dr. Larry Weed published the paper, Medical Records That Guide and Teach, in the New England Journal of Medicine in March 1968, the genesis of the electronic health record. However, no country in the world has yet produced an effective summary care record. Most of the data on patients is segmented into islands of automation in many different systems, and no nation has yet managed to solve that problem. So I think, first of all, we need to develop an effective summary care record so that any clinician responsible for the patient, and there are often many in their lifetime, can access a clear summarized view of that patient's information, demographics, current conditions, current medications, allergies, so forth and so on. So that's a starting point, and I think Qatar faces that problem just like many others in the region, and all nations across the world face. So that's one of the areas, I think. The second area is, I think, standards of ontologies and clinical vocabularies. So, okay, your nation may have chosen ICD-10 moving to ICD-11, or SNOMED, CT, Systemized Nomenclature of Medicine Clinical Terms, as their fundamental system. But they don't have an agreed, perhaps, vocabulary for dictionary of medicines and devices right across the nation, or they don't have an agreed naming convention for lab tests, units of measure and reference ranges, for example. And so I think for our electronic health records and our systems to be more effective, then I think we need to have agreed standards, and I'm working on that at the moment, or attempting to, with the WHO and various other organisations, to see if we can get to that position, because we don't have it in my country or any other country in the world as far as I know. I think in terms of benefit, we also need to support the patient in lifestyle, diet, exercise and mental well-being and medications management. I think we also have to assist the patient to take ownership of their own conditions, particularly in the field of chronic conditions. So in conclusion, I think they're the steps that we need to take to make telemedicine more effective. For at the moment, it appears to me a unicorn. There's much hype around it. Everyone's heard of it, but nobody's actually seen it. So, you know, the talks of McKinsey and so forth, and the move towards telehealth care. Probably we're seeing Amazon in the United States of America taking quite huge steps in that direction, but that's a few years away. And probably in China, which I was asked to speak in a couple of years ago, pre-pandemic, and I was amazed at the developments that I've seen going on there in healthcare and healthcare technology. I was absolutely impressed by their benefit. So, lastly, I think we need some better smart wearables, and we're getting there. We can measure oxygenation. We can measure ECG. We need to be able, many other vital signs. The last one, I think, is the truly non-invasive blood glucose monitor. Truly non-invasive, not Dexicon or Libra. And I think we're probably 1 or 2 years away from seeing a wearable that could measure most of the common vital signs that patients need. And good luck to Samsung, Apple, and Huawei in that. Thank you.
Thank you very much, Prof. Michael. That was very insightful, and thank you for sharing those benefits and highlights. I would like to thank every panelist, all the experts here with me. It was a pleasure meeting everyone. We started this session by stating some facts and highlights in the context of a new era of digital health. We've highlighted also some points with regard to some local facts, for instance, from my point of view, where I do work. Like, we've seen a lot of improvement and huge jump in terms of digital health adoption. We also moved we discussed with Dr. Ahmed also the business models at national level and how actually we scale it up to a more sustainable patient-centric model considering different pillars. And Prof. Rowaida also shared with us the new shift after COVID-19 and beyond, where we actually highlighted the several examples and how basically the near future or the new normal will be more digitally abled. And also we finalized with Prof. Michael talking about the effect of pandemic on telehealth and what are the steps probably need to be taken to ensure the benefits of telemedicine, and probably the major and significant shift might or should consider a preventive care mainly. So thank you so much. I really appreciate everyone here, and I hope you enjoyed the panel. Thank you.
Thank you all very much, and God bless you.
I'll hand it over.
Shukran, as we say.
Thanks, everyone. It's a great session. Thank you very much. I'll hand it over. Would you like to say something, Rowaida? Prof. Rowaida? I've seen your mic on.
Excellent. Thank you so much. Outstanding moderator and panelists.
Thank you so much. Thank you to all of you. Thank you. I'll hand it over to Bridget and Roger, and wish you all the best and enjoy the rest of the summit today. Bye-bye.
Thank you. Thank you very much, eminent panel members, Dr. Safwat, Professor Miller, Professor Rowaida, and our panel moderator, Ms. Safaa, for the interactive and extremely insightful panel discussion around emerging from the impact of COVID-19, a public health perspective. Thank you once again for giving us your precious time and for making this panel discussion an interesting one. I hope all of you have a lovely day ahead.
Thank you. Thank you, everybody.